Hey everyone, this is Michael Davitt,
And I'm Fernanda Sa.
and we're going to be talking to you guys about culturally competent anesthesia care for the Hispanic population.
To start off the presentation, we're going to just give you an outline. So we're going to have an introduction, demographics, discussing traditional health beliefs and cultural practices, then healthcare disparities, and then implying and anesthetic implications. So who are U.S. Hispanics? The term Hispanics does not exist in Latin America and the Spanish-speaking countries. In 1970, the Census Bureau introduced the term Hispanic to refer to individuals of any race who have origins in Mexico, the Caribbean, Central America, South America, or other Spanish-speaking countries. The term Hispanic was institutionalized in 1976 when the U.S. Congress mandated the collection of information about these same populations. In 2000, the term Latino was added to the U.S. Census. Latinos are people of Latin American descent. Often used interchangeably, both terms are uniquely American labels that are widely contested, with no consensus on their full meaning. An additional factor to take into consideration is that not all South Americans are Hispanics, as there are 5 non-Spanish-speaking territories: Brazil, Guyana, Suriname, French Guiana, and Belize, which are currently highlighted on the graph on the right. This concept is also reflected in the Census Bureau, which allows people of Brazilian heritage, for instance, to self-identify whether they are Hispanic or not, but the census does not automatically classify Brazilians who speak Portuguese as Hispanics. In this slide, we're going to discuss more demographics in terms of the population, because as of July 1st, 2016, more than 57 million Hispanics currently live in the United States, which constitutes 17% of the total U.S. population. Between 2015 and 2016, the Hispanic population increased by 2%, which represented more than half of the nation's population growth during that year. Currently, Hispanics represent the fastest growing ethnic minority in the U.S., with a projected population of 119 million by 2060. According to this projection, the Hispanic population will constitute 28.6% of the nation's population by that date. In 2016, 9 states had a population of 1 million or more Hispanic residents, being Arizona, California, Colorado, Florida, Illinois, New Jersey, New Mexico, New York, and Texas. California had the largest Hispanic population of any state, with 15.3 million. A further breakdown of the U.S. Hispanic population demonstrated that 63.2% were of Mexican origin, 9.5% were Puerto Rican, 3.9% were Cuban, 3.8% were Salvadoran, 3.3% were Dominican, and 2.5% were Guatemalan. The remainder 13.8% were of some other Central American or other Hispanic Latino origin. In terms of traditional health beliefs and cultural practices, for family dynamics, the Hispanic culture tends to follow the traditional patriarchal structure, which grants the father or oldest male relative the greatest power, and women are expected to show submission. Hispanics also come from a collectivistic culture where group activities are dominant, responsibility is shared, and accountability is collective. Because of the emphasis on collectivity, harmony and cooperation among the group tends to be emphasized more than individual function and responsibility. Church is a central aspect of the Hispanic patient's life and community. Most Hispanics are Roman Catholic with concurrent beliefs and use of magical religious means of dealing with life. Magical religious is a belief system which combines elements of religion with magical practices. For example, each saint has a specialized general function: Saint Anne for infertility or Saint James the Greater for arthritis. Performing magic rituals to these saints is believed to help treat or prevent certain illnesses. The meaning of health varies among Hispanics. Some maintain that health results from good luck or is a reward for good behavior. Illnesses are thought to have either natural or supernatural causes. Some common folk illnesses, causes, and remedies include humoral imbalance, where in general, physical and mental illness is thought to result from an imbalance between a person and the environment, expressed as either hot and cold or wet and dry. Aspects of hot states include hypertension, pregnancy, acid reflux, and diabetes. Cold states include menstrual cramps, colic, or pneumonia. To correct an imbalance, people consume foods or herbs with the opposite quality. For example, cold conditions are treated with hot medications. Empacho, where an illness results from a dislocation of different parts of the body. For example, upset stomach or indigestion is thought to be caused by eating the wrong food at the wrong time of day, eating undercooked food, or swallowing gum. The most common treatment is rubbing the stomach or back gently with cooking oil and pinching the spine. Another view of health would be the mal de ojo, which is the evil eye, where an illness is caused when someone looks with admiration or jealousy at another person. Folk remedies include saying a prayer while passing an egg over the victim's body, then placing the egg in a bowl under the victim's bed overnight. Susto, which is also known as fright sickness, rises from a traumatic or frightening experience and is thought to cause soul loss, whereby the soul leaves the body and wanders freely. Symptoms include anxiety, depression, insomnia, introversion, irritability, lethargy, and anorexia. Tuberculosis is sometimes classified as susto. Overall, culture is essential in their health habits. A reliance on traditional healing system is common not only because it is culturally approved, but also because of the lower cost involved. Furthermore, their collectivist values or group orientation permeates into their health life, so individuals often look to one another for opinions.
Okay, so now we're going to transition to some of the common healthcare disparities that the Hispanic population faces. So access to care could be impacted by location. While many Hispanics reside near large metropolitan cities, a significant portion of the United States Hispanic population work in rural farming communities where access to care and transportation to health services can be very difficult. Lack of insurance. Most Hispanics work under the table, so they could be paid in cash with no healthcare benefits. They're less likely to have a designated family a designated family health care provider for routine exams, annual checkups, since it's too expensive to pay out of pocket. According to the CDC, more than twice as many Hispanics under the age 65 lack health insurance as compared to non-Hispanic whites. So it's not surprising, therefore, that Hispanics are almost twice as likely as non-Hispanic whites to lack a regular source of health care, which includes important screenings and preventative services, making it more difficult to identify and treat potentially serious health conditions at an early stage. Another disparity would be poverty. In 2014, the median household income of Hispanics was roughly $39,000, which is 52% lower than that of non-Hispanic whites, which was roughly $60,000. In 2016, the poverty rate among U.S. Hispanics was 19.4%, with the median household income being roughly $50,000. Also, what most people do not take into account is that even if U.S. Hispanics have a decent paying job where they have a nice income, a lot of them do send a lot of money back home to their families of their home or native country. Immigration status. As of 2012, the number of unauthorized immigrants in the United States was estimated at 11.2 million, and many of these undocumented migrant workers are employed in substandard, high-risk jobs with risky occupational exposures. Fear of getting deported and the belief that the hospital will report them if they are admitted is a common fear for these patients. This may also contribute to the lack of health insurance, since most believe that if they fill out any legal forms or get added to the federal system, that the government will be able to find them and have them deported. Education and health literacy is another healthcare disparity that Hispanics face. A large amount of Hispanics over the age of 65 cannot read or write English. This leads to poor knowledge of evidence-based practices that can impact overall health. Some never attend school, particularly the older immigrants who are not naturally born in the United States. Education industry in Hispanic countries is not like that of the United States. So for instance, the Department of Children and Families Services will not chase the parents down if they do not enroll their kids in school. So their healthcare knowledge is solely based on cultural beliefs discussed within the family and while growing up. A study conducted by the ASA wanted to determine the Hispanic and non-Hispanic public's knowledge about anesthesia, anesthesiologist expertise, and role of the anesthesiologist in and out of the operating room. So the conclusion of the study basically resulted in most Hispanic patients believe that anesthesiologists are specialist doctors and that they put patients to sleep. But these patients are uncertain of their exact role or function during surgery or outside of the OR. High concerns or fears about devastating complications of anesthesia still remain for these patients. Educational efforts should be directed at this group especially, with the goal of alleviating preoperative anxiety. So communication barriers. Communication limitations can be frustrating to both the patient and provider, and at times can compromise the quality of care, resulting in healthcare disparities. We have a very large Hispanic population in the state of Florida, roughly 4.3 million Hispanics, which is 25% of Florida population according to the United States Census Bureau. Most Hispanics who are not natural-born U.S. citizens do not speak fluent English. So we're encouraged to ask them if they have any questions or engage them more in the topic instead of just assuming that their head nodding and silence means complete understanding of their anesthetic plan. With this being said, it is important that we do not judge them solely on their body language cues, because it is uncommon for Hispanics to be aggressive or assertive in healthcare interactions. In nonverbal communication, maintaining eye contact can be interpreted by Hispanics as a challenge or intimidation. Also use caution when using gestures in nonverbal communication, as some may have adverse connotations within their culture. It is also important to consider most Hispanics are bilingual. However, we should remember to ask them which language they feel most comfortable in discussing their healthcare needs. If a profound language barrier exists, it is important to incorporate a hospital translator or blue phone. Also, do not rely solely on patients' family members for means of interpretation. It is also important to have both English and Spanish consent forms available. Communication barriers may also affect providers' ability to deliver effective monitored anesthesia care, or MAC. So as we are all now aware, this combination of local anesthesia and sedation often requires some degree of patient cooperation. So you must consider if this patient, Spanish-speaking patient, is aware that they might not be completely asleep or unconscious for the procedure. You can imagine how scary or intimidating that could be for them. Another situation that comes to mind is if we're performing an awake cesarean section under spinal anesthesia. How are we to assess the effectiveness of a neuroaxial blockade, or be able to therapeutically give them some verbal anesthesia to let them know that this uncomfortable pressure is a normal occurrence with a C-section? So I think those are all some pretty common concerns you need to have if you have a patient who does not speak any English at all. All right, so now we're going to talk about some of the leading comorbidities and causes of death among the Latino population. Hispanics have different degrees of illness or health risks than non-Hispanic whites. 35% have less heart disease and 49% less cancer. There's a lower death rate overall, but a 50% higher death rate from diabetes or liver disease. You can kind of see this little infographic on the right side of the slide that shows that number 5 and 6 are pretty high compared to the white population. 24% more poorly controlled high blood pressure. So maybe make a mental note that while having these patients under general anesthesia, to expect large fluctuations of blood pressure and hemodynamic instability. So 23% more obesity. The Hispanic population in the United States is disproportionately affected by obesity, with 42.5% of adults currently classified as obese. And finally, 28% less colorectal screenings. Therefore, increased risk of late cancer diagnosis, which is the leading cause of their death among Hispanics. Okay, so for our preoperative assessment, we need to be culturally aware of traditional health beliefs and practices. Some Hispanics have belief in hot and cold practices of balancing sickness. Aspects of hot states include hypertension, pregnancy, acid reflux, and diabetes. Cold states include menstrual cramps, colic, and pneumonia. Some Hispanic people will try to treat hot states with cold remedies and the opposite for the cold states. It is very important to conduct a thorough pre-op assessment and ask your Hispanic patients if they are taking any herbal supplements such as echinacea, ephedra, garlic, ginkgo, kava, and St. John's wort, as all of these can cause serious coagulopathies and other serious anesthetic complications. We may also want to address and respect religious preferences. Religious aspect could include asking whether or not they want to see a priest before going back into surgery. It's also very important to relieve anxiety and build trust. A recent study conducted by the ASA revealed that Hispanics may be more anxious than Caucasian patients about having surgery and also want more detailed information before having a procedure. This certainly makes sense for our Spanish-speaking patients, since communication barriers may leave these patients with unanswered concerns prior to surgery, which further increases their levels of anxiety. So continuing on with our intraoperative concerns, most Hispanics are Roman Catholics, and some may want to take their rosary, cross, or piece of cloth with them to the OR. And as the patient's advocate in the OR, we should try our best to honor their wishes without breaking any hospital protocols or sterility for the procedure. Hispanics, also with darker pigmentation, may have false high pulse oximetry levels when O2 sat levels are actually below 80%. So it's important to take that into consideration. If you think your pulse ox isn't really working correctly, or if you maybe think it's false high, maybe it's just because of their pigmentation of their skin. Moving on to postoperative considerations. Ethnic identity accounts for some of the racial and ethnic differences found in pain sensitivity. In clinical investigations compared with non-Hispanic whites, Hispanics report more severe chronic pain and acute postoperative pain. Experimental investigations have also found that Hispanic participants reported greater pain sensitivity and less pain tolerance than non-Hispanic white participants. And finally, we're going to talk about some of the anesthetic implications for obstetrical patients. It is important for anesthesia providers to know any differences or important anesthetic considerations about the target population to provide optimal care. Historically, Hispanic women have been less likely than non-Hispanic white women to receive early prenatal care. However, in recent years, this gap has been narrowing. Lack of health insurance coverage may make prenatal care unaffordable for many Hispanic women. Additionally, barriers are likely to include language and cultural incompatibility between women and their prenatal care providers, lack of understanding the importance of prenatal care, and fear of the effect of seeking care on immigrant status. Hispanics in the United States have the highest birth rate among racial ethnic groups. Despite being a vulnerable population due to their socioeconomic status and inadequate health care, babies born to Hispanic women, particularly to foreign-born mothers, experience lower rates of low birth weight and mortality compared to national averages. This phenomenon is known as the Latina birth outcomes paradox. All right, so a recent study conducted by the University of Virginia shows that Hispanic women are 53% less likely than all of the races to have an epidural. Some of the most common reasons for declined epidural were Hispanic women believe they should cope with their labor pain, since being strong throughout the process is valued in our culture. They also believe that they have a fear of back pain, and that family and friends advise against that epidural. So basically, as the anesthesia provider, I think it's very important for us to educate these mothers on the benefits of epidural analgesia. With that being said, we also don't want to coerce them into something that they don't believe in or they don't want to do as well. Okay, so in summary, the Hispanic population makes up almost 17% of the U.S. population. Hispanics tend to come from a collectivist cultural group that also follows a traditional patriarchal structure. Hispanics have variable meanings of health and various traditional beliefs for treatment of illnesses. Most Hispanics are either bilingual and or fluent in English, so healthcare providers need to establish patients' preferred language prior to beginning their care. And finally, Hispanics have different degrees of illness or health risks than non-Hispanic whites. So I think that kind of sums everything up for us. Thank you guys so much.